All right, welcome. This is a clinical explainer on Bisoprololo. We're going to do a quick, high-yield rundown for all you practicing clinicians out there, focusing on one of the most common cardioselective beta blockers you'll see.
Okay, so let's just dive right in. What exactly is Bisoprololo? Well, it's a beta blocker, but the key word here is selective. It's highly selective for those beta-1 receptors in the heart. And, that selectivity is really the secret sauce to how it works and its side effect profile, especially when you're using lower doses.
So where do we use it? Well, its main gigs are hypertension and angina. But, and this is super important, it's also a cornerstone therapy for stable chronic heart failure, the kind with impaired systolic function. Its whole job there is to improve outcomes on top of the standard stuff like ACE inhibitors and diuretics.
Okay, so here's our game plan for this explainer. We'll kick things off with its mechanism, then get into the nitty-gritty of dosing, cover the big warnings and absolute no-goes, look at drug interactions, and wrap up with its use in pregnancy and lactation.
All right, Section 1. Let's start with how this drug actually works and where it fits into our clinical toolkit. So, the magic of Bisoprololo really comes down to its cardioselectivity. By zeroing in on those beta-1 receptors in the heart, it does two main things. It slows the heart rate and it reduces the force of each pump. Think about it. That means less work for the heart, which lowers its oxygen demand and brings down blood pressure. And here's the really neat part. At the usual lower doses, it pretty much leaves the beta-2 receptors in the lungs alone. That's a huge clinical advantage, right?
Okay, let's talk dosing. This is where things get really specific, especially for chronic heart failure. You can't just jump in. It requires a very careful step-by-step approach. Now look at this. This is the mandatory, slow and steady titration schedule for heart failure. You have to start low. We're talking just 1.25 milligrams, and then you slowly creep the dose up week by week, only if the patient is handling it well. This isn't something you can rush. It means you've got to be watching their vitals like a hawk to make sure you don't tip them into decompensation, hypotension, or a dangerous bradycardia. And this chart really drives the point home. See the difference? For hypertension or angina, you're usually starting at 5 milligrams and can go up to 20. But for heart failure, whoa, you start way lower at 1.25 and the max dose is only 10. It just shows you how much more delicate that situation is.
All right, this next part is all about clinical vigilance. These are the warnings and precautions that you absolutely have to keep in your head every time you think about prescribing Bisoprololo.
So, a big one to think about is, what about your patients with diabetes? This is a classic clinical trap if you're not paying attention to how it interacts with glucose regulation.
Here's the problem. Bisoprololo can mask the warning signs of hypoglycemia. You know that racing heart, the tachycardia, that usually screams, "my sugar is dropping"? Well, Bisoprololo can completely blunt that. So your patient might not get that critical warning sign. This means you have to be extra careful and, just as important, you have to educate your patients on spotting other symptoms.
And there are a few other special situations to keep on your radar. First, surgery. The anesthetist has to know the patient is on it because it can change how their body responds to things like blood loss. Next, asthma and COPD. Look, Bisoprololo is cardio-selective, but it's not cardio-absolute, so you still have to be cautious. Start low, watch them closely. And finally, keep an eye out for skin issues because it can sometimes trigger or worsen psoriasis, and it can also make symptoms of peripheral artery disease a little worse.
Okay, and this might be one of the biggest take-home messages of all. Do not stop Bisoprololo abruptly. Seriously, don't do it. You can get this nasty rebound effect, a beta-adrenergic supersensitivity that can cause rebound hypertension, make their angina worse, or even trigger a heart attack. You have to taper it off slowly, usually over 1 to 2 weeks at least.
Okay, so we've talked about warnings. Now let's get into the absolute contraindications. These are the situations where you just don't use it, period.
Simply put, in these cases, the risks are just way too high. It's a no-go.
This list is non-negotiable. We're talking about acute or decompensated heart failure, where they need IV inotropes, cardiogenic shock, and serious heart block, like second or third degree. Also, if the patient already has symptomatic bradycardia or hypotension, you can't give it. And, of course, severe asthma is a big one. Even with its selectivity, the risk is just too great.
All right, on to drug interactions. You have to be aware of what other meds your patient is on because some combinations can be pretty dangerous.
So, let's look at this. The big ones to avoid, the not recommended combinations, are things like verapamil and diltiazem, those calcium channel blockers. Put them with Bisoprololo and you're risking severe hypotension and AV block. Then you've got the use with caution category.
This includes things like NSAIDs, which can actually make the blood pressure lowering effect weaker, or digitalis, which can make the bradycardia even worse. So not a hard no, but you definitely need to be careful.
And finally, let's touch on a really important and sensitive topic: pregnancy and lactation. This is always a tough call, balancing the health of the mother against any potential risks to the baby.
So you can see here the risk profile is different for each. During pregnancy, it's a real judgment call. The big concern is that it can reduce blood flow to the placenta, which could lead to fetal growth restriction. So you'd only use it if the benefit to the mother is absolutely essential. Now, breastfeeding, that's a different story. It's generally a not recommended situation because we don't know for sure, but there's a risk it could accumulate in the infant and cause problems.
And if a mother was on bisoprolol toward the end of a pregnancy, you absolutely must monitor that newborn closely for the first 72 hours. What are you looking for? The classic signs of beta blockade: low blood sugar, a slow heart rate, and any signs of respiratory depression.
So we've covered a lot, right? From that super careful titration and heart failure to the absolute red flags. So I'll leave you with a question to take back to your practice, thinking about its high beta-1 selectivity. When are those specific clinical scenarios where you would reach for bisoprolol over another beta blocker for one of your complex patients? It's something to think about.